Today, our presenters will be Catherine and Bernard, who manage the HMDC, and they'll be covering some updates to the business rules and the data specifications and dictionaries, showing us some examples of how the admitted activity data is collected and used, and what is next coming up for these collections. I'll hand you over to Catherine.
Thanks, Kat. So as Kat said, I'm Catherine. I'm the Acting Principal Data Management Officer, and I'm here today with Bernard Sharp, our Acting Data Management Officer, to take you through the hospital morbidity data collection, which covers all admitted episodes of care, and also the elective services waitlist data collection, which contains all waitlisted events. So today we're going to talk to you about the HMDC and elective services waitlist pad changes, give you insight into how the data is used, and also talk about what's next in this space for us. So one of the changes that was introduced to the HMDC business rules was around medical records and the requirements for admitted activity to be documented correctly. So audits found that there were often issues with the placement of documentation within medical records, with documentation often misfiled or combined with each other. So this caused issues with the abstraction and the allocation of ICD codes, as well as being unable to determine the location of when patient transfers occurred. So the audit identified that various hospitals were using different methods to determine the decision time to admit. Some were documenting the date and time in forms within the medical record. Some said that they considered the bed slip requests in enterprise bed management as the decision time to admit, and some said it was the emergency department information system decision time to admit as the calculation time. So in some cases, it was also found that the decision time to admit wasn't documented in the medical record. So we added some clarification around the requirements for correct documentation in section 5.4 of the business rules, with the aim of trying to emphasise the importance of consistent and procedural recording of the medical record. We added a section describing that medical records can exist in a physical, digital and/or electronic form, and that it's fine for supporting systems or clinical applications to be considered an extended part of the medical record. However, the critical aspect is that there are local procedures in place that evidence this as the standard practice. We tried to further emphasise the importance of accurate recording of information by stating in the business rules that while the medical record serves the patient as a history of their care interactions, it's also required for mandatory audit purposes and also for meeting our legislative funding agreements and record keeping requirements. Another new addition to the business rules is the inclusion of content related to high-cost therapy. So high-cost therapy is a medical treatment that is highly specialised to the person, and it uses the body's own immune system in the treatment of illness. This is an emerging field and currently only offered to a small number of patients in WA. This new section of the business rules outlines what hospitals providing high-cost therapy are to provide to the department, so the UMRN, activity type and the date of the event, which the Department of Health uses for IPA funding. Another one of the major changes to the business rules this year was the inclusion of content related to Medi-hotels. So the Medi-hotel section of the business rules outlines what a Medi-hotel is, when someone is to be admitted to a Medi-hotel, and also how to record their care. Patients will be admitted to a Medi-hotel as a boarder, and the standard boarder requirements apply. I'll now hand over to Bernard to take us through the HMDC and elective services waitlist data dictionary and data spec changes.
Thanks, Catherine. So first, I will briefly explain what these documents are. So the data dictionary lists out each data element and provides details about each field. It provides a definition, data type, format, list of permitted values if applicable, guide for use, and some examples. The data specifications, on the other hand, provide a more technical overview of the reporting requirements. So as data is entered into WebPAS or other PAS systems, there are processes in the background to extract and provide this data to us here at DOH. So the specifications outline the format that the data submissions need to be in, the schedule for how often it needs to be sent, as well as a listing of every data element that is required and its position within the submission file. So regarding data dictionary changes, we received a number of feedback items from stakeholders. So we added some additional explanatory content for fields, including discharge to, mode of separation, employment status, and care type. We removed the use of the word abscond from the mode of separation. This was based on feedback that this terminology is associated with avoiding prosecution and should be removed from WA Health vocabulary. So this has been replaced with the wording leave without notice instead. Elsewhere, we provided some more meaningful examples and clearer definitions for a few fields. We also standardized the guide for use for a number of elements so that they match other data collections. So the elements that we standardized are Aboriginal status, Australian state or country of birth, date of birth, establishment code, language for interpreter, and sex. We also updated any references to ICD-10 AM 11th edition to ICD-10 AM 12th edition, and the coding team will talk more about ICD coding later in today's presentation. Regarding the changes that we made to the HMDC specifications, there is nothing too major. So we noticed some inconsistencies between the specifications and the data dictionary, where some field name descriptions and permitted values did not match. So these had to be corrected in the specifications. There was also a fix applied to the requirement status of the Medicare card number. So this is a conditional field, but it was listed as not mandatory. This element is actually required if there is a funding source of Australian healthcare agreement selected. Next, I will talk about the work that we did with the elective surgery waitlist documents. So for context, the primary purpose of this data collection is to collect waiting time information regarding patients who are placed on the elective services waitlist. Data in this collection contains information about patients who, at a given point in time, are on the waitlist for an elective procedure, have been admitted from the waitlist, or have been removed from the waitlist. Elective care is care that is medically necessary but can be delayed for at least 24 hours. People who need emergency treatment will not be placed on the elective surgery waitlist. Currently, we don't have a business rules document for this collection, only a data dictionary document and a data specifications document. We didn't receive as many submissions for changes to this collection. There was only one formal piece of feedback, although we did apply some minor improvements and clarifications ourselves. The formal feedback highlighted that the excluded procedure indicator field, which is a field that indicates whether a procedure can be performed in a public hospital on an elective basis, in the data dictionary, contained a list of procedures that were out of date. So this has now been replaced with a link to the latest document. It was also highlighted that the reportable procedure indicator field, which indicates if the case is reportable to the Commonwealth, contained a link to an old document which was no longer in use. Additionally, like the HMDC documents, any references to ICD-10 AM 11th edition were updated to ICD-10 AM 12th edition, and the data definitions for several fields were standardized to match with other data collections. For the ESWL specifications, the only changes that were made were to update our contact information to show the admitted team's new email address, and also update some dates in the example file name for a submission. Next, I will talk about some of the practical uses of how the data in these collections is used. So a key requirement for both HMDC and ESWL collections is to provide mandatory reporting to the Commonwealth. So we also need to meet internal reporting requirements such as weekly and monthly reports to HSPs and to provide data for performance indicators. The data in these collections is also used for other ad hoc or regular data requests, including research projects. Regarding our national submissions, we're required by the Commonwealth to submit HMDC and ESWL data to national bodies on a regular basis. The two main national bodies that we report to is AIHW, which is the Australian Institute of Health and Welfare, and IPA, which is the Independent Hospital Pricing Authority. AIHW is an independent statutory federal government agency that provides information and statistics to the public. So they collect data from state, territory, and federal government agencies, and they produce reports and help make data available to government agencies, universities, research centres, and non-government organisations. IPA is also a federal government agency, but they are more focused on activity-based funding of public hospital services across Australia. When we provide data to these bodies, we need to run it through their validation checks. So as part of standard process at DOH, the data quality team here at DOH perform checks on the data that we receive, and they will go into more detail about this aspect later in the presentation. But the national process is effectively an additional data quality step. So it's crucial that we're able to provide high quality data to these national bodies to help inform and support better policy and service delivery decisions, which ultimately leads to better health and well-being outcomes for all Australians. As for some other uses of the data, there are many interesting examples of where data in our collections is used to support important outcomes in the community. One of the regular data requests that we receive is from the Road Safety Commission, who compile a road trauma trends report. So this is a publication that provides statistics relating to road crashes in WA, and it can be used to provide visibility over all types of road trauma, not only involving cars, but also pedestrians, cyclists, motorcyclists, etc. So it's good to know that the data in our collections is helping to inform and provide a better understanding of injuries and hospitalizations in this area, and is being used to help inform policy at a state level. Data from our collection is also used in a wide array of research projects, from diabetes studies to mental health projects, palliative care studies, heart disease, and more. An interesting data request we had recently was around pediatric patients that are hospitalized with burns. So it could be due to contact with hot substances, water, steam, etc. And this was being used to help inform plumbing codes. So it's great to see examples like this where data in HMDC is used for important community outcomes. So this leads us to what's next for our collection. So one area that we're keen to get addressed is around sex and gender. So the HMDC data dictionary states that the sex field is understood in relation to sex characteristics, such as chromosomes, hormones, and reproductive organs, but it's often used interchangeably with gender. However, they are distinct concepts. So while sex is about sex characteristics, gender is about identity, expression, and experience. Current practice is to record sex at the time of presentation to the hospital or health services. It's not necessarily the sex assigned at birth. So longer term, we're keen to see both sex and gender captured in WebPAS. So there is certain legislation around this that HSPs should be aware of. So in particular, if a patient wishes to have their sex changed in WebPAS and can provide an updated birth certificate reflecting their current sex, then the sex in WebPAS must be changed. So there are acts that require us to amend a person's sex in this situation, and the Patient Master Index Officer is authorised to update the patient's sex information when they have an updated birth certificate. Anyone with an interest in the work that is happening around sex and gender can contact the metadata team for more information, and they can be contacted at metadatastandards@health.wa.gov.au. I'll now hand over to Catherine to talk about our future aims for the waitlist collection and what else is next for our team.
Thanks, Bernard. So another one of our aims is to create the Elective Services Waitlist Business Rules document. Many queries can be answered by looking at the data dictionary or the data specifications, but we would like to create an overarching business rules document that would be available to provide an overview of the collection and to also go into some of the intricacies of elective services. In total, between the hospital morbidity data collection and the elective services waitlist collection, we received a total of 24 formal submissions for feedback. However, we're always looking out for any issues or areas for improvement with our documentation. Throughout the year, we fielded many queries from HSPs and business users and are always looking for any suggestions or changes that may be required for the following year. So please drop us an email anytime if you have any changes or think something needs to be added or clarified in any of the PAD documents. Thanks for listening to our presentation. I'll now pass back over to Kath to coordinate some questions.
Thank you, Catherine and Bernard. How interesting. Great to see that the audits are identifying some quality assurance, improvements, documentation, and who would have thought that our data would inform the plumbing codes? There you go. We do have a couple of questions that people have sent in. You've already answered one of our questions we trusted that was about the sex and gender data. Another question that we have had is, what is the master file we've heard about and how does someone get access to it?
Sure. So the master file is something that we've introduced recently. So it's a way for staff to access the admitted data themselves without having to put in a data request. So it's all admitted data in one central location and HSPs can access other HSPs information. So say, for example, if someone in North Metro, say, for example, if someone in North Metro was working on a project and they needed to know how many people, say, had their appendix out last year in WA, they'd be able to go into the master file and see all appendectomies performed in North Metro, South Metro, East, etc. So each HSP, including the Department of Health, has an administrator who provisions access to the master file. If this is something that you would like to have access to and you want to query some of the data yourself, by all means, send us an email to doh.admittedDataCollection@health.wa.gov.au and we'll be able to put you in contact with your local administrator to get access.
Great, thank you very much. Well, we don't have much more time for more questions. We did have a couple more, and thank you very much for those of you who sent a couple in. We'll make sure that we get back to you afterwards out of session to respond to those questions. Moving right along.
I think there was one other question. I think we do have a couple more minutes.
Oh, good, sorry. I thought I was getting the signal. Okay, if you're an external researcher, and perhaps you don't have access to that master file, obviously, how do you get the data that you want from the hospital morbidity data collection?
Yeah, I can jump in here. So if you don't have access to the master file, or also for any other data requests that are more complex and can't be solved with the master file, the best option is just to contact the admitted data collection team via our mailbox, and we can review the request and forward it on to an analyst here at DOH to extract the data. For any research-related queries, such as from external university researchers, the request must go through the Research Data Services team, as approvals and justification is required. So they can be contacted at dataserve@health.wa.gov.au. And for any other external queries, there are formal processes at DOH that must be followed. Any other external queries can be sent to ISPD Client Services at health.wa.gov.au for allocation and provisioning.
So it sounds like there are a couple of formal processes people have to go to. How long does it take for data to become available?
Yeah, so there is a bit of a time lag between when data is first entered into patient administration systems to when it can be extracted from HMDC. So the data specifications document goes into this in more detail, but data can take up to 3 months before it is available for extraction. So at DOH, we require establishments to provide data for the previous month by the end of the month. So for example, data for the 1st of January to the 31st of January needs to be provided by the 28th of February. And then there is up to 2 weeks given for establishments to correct any validation errors. So for example, January data should be finalised by the 14th of March. The reason for this time lag is that there is an extensive validation process that occurs to ensure that all data submitted to HMDC is complete and of a high quality. So any errors or unexpected data is returned to sites for clarification and or correction. This process is managed by the data quality team, who will be speaking later on in the presentation. Ultimately, data can be queried for internal purposes or for HSB queries once it's passed all validation processes. Data is made available in the master file once it's fully validated, and this can be anywhere from 1 to 3 months after the separation date. In general, for external queries, we usually provide data up to the last completed quarter.
Great, thank you. We just have one more quick question from Matt. How will that sex gender determination be flowing into feeding other peripheral systems such as, for example, solars?
So that's something that is obviously something that we're going to have to look into in the future. So we do have a working group here at Department of Health who is looking at all the flow and effects of changing the way sex and gender is recorded. So more of that will be announced sort of in due time. So it is something that we're aware of and something that we'll be making changes to.
Thank you very much, Catherine and Bernard.